Hello, my name is Anna Christina Janae, and I'm from the Cognition of Crazy Group 2. For my presentation, I did it on autism spectrum disorder. For the first experiment, it looked at eye-gazing cues in typically developing children and high-functioning autism children. The theory for this study is that high-functioning autism children do not know how to use eye-gazing cues to understand the other person's mental state. There were two hypotheses in the study. The first one is that high-functioning autism children cannot effectively utilize statistic line drawings of eye-gazing cues to orient visual spatial attention. The second hypothesis is that the participants with high-functioning autism deploy attention in an abnormally slow manner. The independent variable for the study is the eye-gazing cue test, and the dependent variable would be the difference between the high-functioning autism and the typical developing group. The methods for the study is there was 81 participants, 22 with high-functioning autism, and 49 that were typically developing. That all ranged from the ages of 8 to 13. Participants sat 80 centimeters away from the screen and were instructed to hit the spacebar when they saw a star in the peripheral box. There are 4 images shown here as an example is what they were shown on the computer screen. First images was crossed with 2 empty peripheral boxes for 750 milliseconds. The second image was a set of eyes, nose, and mouth in between 2 empty peripheral boxes for 200 milliseconds. The eyes were either gazing to the left or right empty box. The third one was either shown for 0 or 500 milliseconds with a cross with 2 empty boxes. And then finally, you would have a star appear in either of the empty peripheral boxes. There were valid and invalid trials. Valid trials mean the eye-gazing cues predicted correctly where the star was going to appear, and the invalid trials were that the eye-gazing cue did not correctly predict where the star was going to appear. There are also catch trials. That means that there was no third image between the eye-gazing cue and the star appearing. Each participant went through 4 block trials, which consisted of 60 trials each. 12 were catch trials, and 48 were regular trials, with 50% being valid and invalid. The methods for the study is there was 81 participants, 22 with high-functioning autism, and 49 that were typically developing. That all ranged from the ages of 8 to 13. Participants sat 80 centimeters away from the screen and were instructed to hit the spacebar when they saw a star in the peripheral box. There are 4 images shown here as an example is what they were shown on the computer screen. First images was crossed with 2 empty peripheral boxes for 750 milliseconds. The second image was a set of eyes, nose, and mouth in between 2 empty peripheral boxes for 200 milliseconds. The eyes were either gazing to the left or right empty box. The third one was either shown for 0 or 500 milliseconds with a cross with 2 empty boxes, and then finally you would have a star appear in either of the empty peripheral boxes. There were valid and invalid trials. Valid trials mean the eye-gazing cues predicted correctly where the star was going to appear, and the invalid trials were that the eye-gazing cue did not correctly predict where the star was going to appear. There are also catch trials. That means that there was no third image between the eye-gazing cue and the star appearing. Each participant went through 4 block trials, which consisted of 60 trials each. 12 were catch trials, and 48 were regular trials, with 50% being valid and invalid. Results. The results consisted of 60 trials each. 12 were catch trials, and 48 were regular trials. The results supported that high-functioning autism children cannot effectively utilize statistical line drawing of eye-gazing cues to orient visual spatial attention, but do not support that participants with high-functioning autism deploy attention in an abnormally slow manner. The eye-gazing cue hypothesis was supported because high-functioning autism groups did not have a difference in time between valid and invalid trials, but the typically developing group reacted faster to valid trials. The high-functioning autism deployed attention in a abnormally slow manner was not supported because high-functioning autism did not react any slower than 700 milliseconds. In the study of Versa and Rizzo, they did a study about patients who had frontal lobe damage and found that similar results to that they could not utilize eye-gazing cues. Seeing the same results in the frontal lobe damage patients makes me believe that autism children have some type of deficit in their frontal lobe, and depending where you are on the spectrum, the worse in the deficit in the frontal lobe. Without being able to use eye-gazing cues, they cannot tell when someone is feeling uncomfortable or want to get away from the situation. These are normal nonverbal cues that we all use to understand what someone's going through or how they're feeling, even if they're not potentially saying it. Without having these cause these high-functioning autism children to have bad social interactions, and that it increases their chances of getting isolated. My second experiment on autism spectrum disorder was about sensory responses and social interactions. The theory for the study was that children with autism spectrum disorder have abnormal sensory experience to limit their social competence and social communication behaviors. The hypothesis for the study is that children with autism spectrum disorder will show more impairment in their sensory responses, social competence skills, and joint skills than typically developing group. The independent variable would be the sensory response, and the dependent variable, how well are they with the social skills and joint attention. The methods was that there was a total of 38 children, 18 children with autism spectrum disorder, and 20 children typically developing. There were 2 laboratory visits a month apart with a follow-up questionnaire a year later about the children's social competence with peers. First visit was that the cognitive and language abilities were assessed, and the parents with autism spectrum disorder children completed an autism diagnostic interview revised, or ADIR. Second visit went over the early social communication skills with the ESCS, was measured by recording the child's interaction with various toys. An adaptive version of the ESCS was used to capture the initiating joint attention and response joint attention. The video was shown to someone that had a blind child diagnosis. For the questionnaire, they used Child Behavior Scale, CBS, to assess the social competence with peers that the parents provided. The results supported that the hypothesis that children with autism spectrum disorder will show more of an impairment in their sensory responses, social competence skills, and joint attention skills than typically developing group. Autism spectrum disorder children have more multi-sensory failures and have lower levels of social competence, indicating that they are less prosocial and more likely to be excluded by their peers. Non-social and social sensory hypo-responsiveness is significantly positive related to aggression with peers. Autism spectrum disorder are less likely to initiate joint attention, IJ, than typically developing children, but there is no difference between reaction joint attention, RJA. Initiating joint attention did not change with social sensory hypo-responsiveness, but typically developing group had an increase in initiating joint attention. The difference between hypo-responsive and hyper-responsive is hyper-responsiveness. It refers to the higher threshold response to a stimulus, and the hyper-responsiveness refers to the avoidant behavior reactions to a stimulus, and the hypo-responsive refers to the higher threshold response to a stimulus. So for hypo-responsiveness means that for a stimulus, it takes a lower end stimulus to arouse them, and that they have a higher response to that stimulus. And for hyper-responsiveness, they have more of avoidant behavior towards the stimulus such as music. So when children hear music and someone talking, they kind of want to get away from that situation, and they have more of a reaction that makes them seem weird, or people don't want to deal with it because they don't quite understand what they're going through, which causes them to be more excluded and people not wanting to bring them around in certain situations because it's a lot to handle. If autism spectrum disorder children cannot or do not want to initiate joint attention, this limits their social interaction because most communication is wanting to tell someone what you saw. Autism spectrum children are more sensitive to social hypo-responsive and hyper-responsive, not so much non-social. As shown here is the initiation, joint tension, and sensory responsiveness to the left, and that you can see that the typically developing group initiate in more joint tension than typically developing in hyper-responsiveness, which means avoidant behavior. No, hypo-responsiveness, which refers to higher threshold into stimulus. And then over to the right, the social competence and responsiveness, you can see that their social competence problems increase in autism spectrum disorder children, then typically developing in the social sensory hypo-responsiveness and the non-social hypo-responsiveness, and social sensory hyper-responsiveness and the non-social hyper-responsiveness.
Some of the theories provided for selective attention is that the deficits come from a failure of top-down mechanisms in which voluntary control is independent of the stimulus and is affected by the prior knowledge, whereas other theories provided that deficits come from the bottom-down mechanisms, such as failure to filter relevant and irrelevant when giving new stimulus. Deficits in selective attention has been widely reported in patients with schizophrenia and is also known as a process that involves the conscious maintenance of directing of one's attention towards a certain stimuli while ignoring the unimportant ones. The purpose of this study, the effect of distracting noise on the neuronal mechanisms of attention in schizophrenia, is to discover if the neuronal response to distracting noise is linked to attention in patients with schizophrenia. The distracting urban noise in this instant is the independent variable, and the dependent variable is our neuronal response to presence or absence of the noise. The distracting noise stimulus is meant to present a busy urban setting, and the subjects are then placed in this setting. Researchers hypothesized that noise effects in hippocampal hyperactivity will be connected to a failure to appropriately engage in selective attention-related network in schizophrenia. Other studies have suggested that the hippocampus is involved in cognitive processing, temporal sequencing, and formulating sequences between objects and the environment. The hippocampus also plays a large role in cognition in terms of spinal cognition and spinal memory formation, so it is also hypothesized that hippocampal dysfunctions is one cause of cognitive decline in schizophrenic patients. The researchers had 39 subjects. Of the 39 subjects, 22 were schizophrenic patients, and 17 were just normal subjects. Of the 22 schizophrenic patients, 4 were women and 18 were men, and the mean age was 37.6. Of the normal subjects, 8 were women and 9 were men. The mean age was 24.7. All subjects were performed hearing tests prior to the study to make sure that the results were not from the effects of hearing differences from both sides of their ears. During the experiment, the researchers had the subjects perform a spinal selective attention task while in the presence of distracting urban white noise, which consisted of a mixture of audio clips, including that of multiple conversations, radio stations, and environmental noises, and also in the absence of the noise. The auditory task that was used was the oddball paradigm, where it requires the behavioral action from the subjects, such as pressing a button when the subjects respond to a deviant. In this case, the subjects listened to a series of tones in 7 blocks or groups. The standard tone was at 1000 hertz, and a deviant was shown. The deviant was a 250 hertz higher tone than the 1000 hertz, and was placed in the third or fourth or fifth block, and each block was separated by 750 milliseconds. The noise was administered to both ears but presented one at a time, in each ear, one at a time. The results in the study showed that both the normal subjects and the patients with schizophrenia performed the selective attention task with comparably high degree of accuracy, but the schizophrenic patients' reaction times were slower than the normal subjects across all of the conditions. Performance by the healthy subjects were 98.5% during the silence and 96.6% during the distracting noise. And the patients with schizophrenia performances percentage were at 93.8% during silence and 94.1% during distracting noise. However, the reaction times for the patients were 573 milliseconds, whereas in comparison subjects were at 460 milliseconds, which ultimately shows a 113 millisecond difference between the two groups. In this slide, we just have a chart, a graph that shows the reaction time of the controls in schizophrenic patients, and it shows that the schizophrenic patients had a greater reaction time, so it took them more time to react to the noise. For the second study, visual attention deficits in schizophrenia, the researchers hypothesized that failure of selective cognitive attention is related to positive symptoms such as hallucinations and delusions for patients with schizophrenia. For their method, they had 14 schizophrenic patients, of whom 4 were female and 10 were male, aged 17 to 60, with 14 control subjects, of whom were 7 male, 7 female, aged also 17 to 60. The criteria for both of the groups was corrected to normal vision. For experiment 1, the stimuli was several dimensions, which is color and shape. The visual targets had either a round or jagged shapes and purple or orange color. It also included 2 homogeneous blocks along with 2 orthogonal blocks. The homogeneous blocks had variations in colors, but the shape was kept constant, and in the orthogonal blocks, the shape and color varied randomly. In the second experiment, the participants were also presented with 2 homogeneous blocks that varied in height but not width, along with 2 orthogonal that varied randomly in height and width. The shape presented in experiment 1, along with the height shown in experiment 2, were defined as a task-irrelevant dimensions. The general procedure for both of the experiments were that participants were directed to press either the left or right cursor button with the dominant hand as quickly and accurately in terms of the color in experiment 1 or the width in experiment 2 when they were presented with the visual stimuli. The experiments consisted of 160 trials, and SPSS 17 was then used to analyze the data from both experiments. This next slide, I just wanted to show the stimulus that was presented to better understand the experiments. So the one on the left is going to be from experiment 1, and the one on the right is going to be from experiment 2. The results of the study, the second study, was that the reaction times for schizophrenic patients were higher than that of the control group in both conditions, suggesting that the patient group was unable to select the task-relevant information in one dimension, such as color from experiment 1, without their attention being disrupted from the irrelevant information such as shape. And also, large interference was shown with experiment 2's irrelevant stimulus, which is height, and the relevant stimulus, which is width. The results show support for the original hypothesis. And then here we have a chart of the reaction times from the schizophrenic patients. The darker one is from the schizophrenic patients, and the lighter one is from the control group. And it shows for both experiment 1 and experiment 2. To conclude, the interpretation of both studies provided support for delayed processing selective attention information in schizophrenic patients, and also an important relation between attention and cognition. This is connected to cognition because attention and cognition cooperate to perform tasks. Attention is the control of sensory input, and cognition is the thought process through learning accumulation. It's also connected by the functions of the hippocampus, as stated earlier. Through these studies provided, the information shows how schizophrenic patients are affected by deficits of auditory and visual attention that contribute to schizophrenic disposition, which can also be correlated to theory of mind, specifically in regards to learning and memory, that will be explored in the following.
My part of schizophrenia in our clinical cognition presentation had to do with theory of mind. The first study that I chose shows theory of mind deficits and cognitive abilities along with general intelligence. The purpose of this first study was to identify the influences of non-theory of mind cognition as well as general intelligence on the performance of theory of mind in individuals that are at ultra-high risk for psychosis that are currently diagnosed with schizophrenia. One thing to note before the studies is what theory of mind is, which is the ability to use beliefs, desires, intentions, and knowledge and be able to attribute them to somebody else as well as their actions. The first study, the theory was that cognitive abilities as well as general intelligence and theory of mind abilities are correlated within individuals with schizophrenia that are at ultra high risk for psychosis specifically. The hypotheses here are that individuals would need cognitive abilities in order to perform theory of mind tasks and vice versa. The method that they used for this first study, they gathered 55 schizophrenia patients, all that were at ultra high risk for psychosis, as well as 58 healthy controls, and they had them both complete neurocognitive verbal and nonverbal theory of mind tasks. The 55 schizophrenic patients were recruited from the Seoul Youth Clinic in South Korea. This study used the Wisconsin card sorting test along with the California verbal learning test, and also a theory of mind tasks which consists of a short story or cartoon tasks, as theory of mind studies usually do. They then took all of these tasks and put them together and correlated them to see what the results would show. The results showed that the schizophrenia subject performed worse on both the verbal theory of mind tasks as well as the cognitive tasks that weren't theory of mind related, including those that involve attention, executive function, strength, and management of working memory. I interpreted this as schizophrenia patients performing worse on all tasks, including theory of mind tasks. This to me showed a correlation between this and cognitive abilities. The second study that I chose, relating theory of mind to schizophrenia, shows theory of mind impairments and their clinical correlation to schizophrenic patients. The theory that this study showed is that there is a similarity and a uniqueness of these theory of mind deficits across schizophrenia patients as well as other mental illness patients, and their cognitive functions. The hypothesis from this study was that patients with schizophrenia, bipolar disorder, and major depressive disorder would exhibit significant theory of mind impairments compared with healthy controls, and amongst these patient groups, the hypothesis was that the schizophrenic patients would show the greatest theory of mind impairment out of all four. The second schizophrenia theory of mind study gathered 140 subjects with 4 groups of 35 members each. The first group were diagnosed with schizophrenia. The second group were those that were diagnosed with bipolar disorder. The third group were those that were diagnosed with major depressive disorder. And the final group were the 35 that were healthy controls. Although we are focusing on the first 35 that were diagnosed with schizophrenia in this matter, it is important to take the other 2 into consideration because we can relate them, we can compare the findings with each other and go from there. The Yoni task was used to analyze the cognitive and affective components of theory of mind by analyzing the facial expressions, verbal cues, and the eye gaze. The task requires participants to judge the different mental states that a cartoon will be showing by analyzing the facial expression and verbal cues as well as eye gaze. The results of this task showed that all of the patient groups showed deficits in the second order of theory of mind, with the patients with schizophrenia and bipolar disorder testing significantly worse than those with major depressive disorder and healthy control group. However, only patients with schizophrenia showed deficit in both the first order and second order of theory of mind in the cognitive component. Now, to put it simply, theory of mind has many orders. The only ones that they focus in this study are the first order and the second. The first order theory of mind is the ability to think of what someone else thinks, usually requiring two separate parties, while the second order of theory of mind is the ability to think or be able to predict what another person is thinking about a third person, and this one uses three separate people. My interpretation of this study was that the hypothesis was indeed supported by the results, and with this we can predict a correlation between schizophrenia patients' cognitive deficits as well as theory of mind. This chart is very simplistic and it has the different effects shown. The schizophrenia on the left, the major depressive disorder right next to it, bipolar disorder to the right of that, and the healthy control, of course, testing best out of all of them. And then to the right shows different lines, solid lines, streaked lines, and then further spaced out. And these shows that schizophrenia tested worse, comparing in all aspects in first order as well as the second order. Connecting this to into cognition, I believe that schizophrenia and theory of mind, they have a direct correlation, and although schizophrenia might not be affecting theory of mind itself, schizophrenia definitely has an effect on cognitive abilities, which then have an effect on theory of mind abilities, and I interpreted this as having a cycle of deficits. With theory of mind being lowered, it decreases the level of analyzing and being able to learn as well as storing memory, and then from there it keeps cycling forward. Another area of research that we have with studies of mental illness and deficits in cognitive abilities are those of studies in post-traumatic stress disorder. The following chapter discusses these.
In the first study I found on PTSD, it involves looking at non-memories, or more commonly known as false memories. The theory was to establish whether people with PTSD experience elaborative non-memories more frequently than non-PTSD participants, and whether involuntary memories are as comparably visual, distressing, vivid, here and now, and emotional as involuntary memories about trauma. There were three hypotheses for this study. First, probable PTSD participants would experience more elaborative non-memories than non-PTSD participants. Second, people with probable PTSD would experience more involuntary cognitions that are predominantly visual and emotional. These are like memories for perceived events than non-PTSD participants. Finally, non-memories would be phenomenologically comparable to memories. For this study, they used Amazon's Mechanical Turk, which is a crowdsourcing online resource, and they obtained 1,215 participants. The participants included U.S. residents only, being between the age of 18 and 87 years old, with trauma being experienced at minimum a month prior to this study and going all the way to decades. For this study, participants were given multiple surveys, some of which included the PTSD checklist, anxiety and depression scale, the global rumination scale, and the involuntary cognitions questionnaire. To complete these surveys and studies, it took about 15 minutes. Once completed, the participants were debriefed and informed of the nature of the study. Further steps were taken to offer resources such as counseling and psychological aid to participants that requested it. Results of this study. For the first hypothesis, the probable PTSD participants would experience more elaborative non-memories than non-PTSD participants was in fact supported. And what they found was that those probable PTSD participants had very vivid emotional and here and now aspects to their non-memories. So it felt as if these memories were real, that they weren't false, that the participants felt as if these non-memories had actually happened and were genuine memories. For the second hypothesis, people with probable PTSD would experience more involuntary cognitions that are predominantly visual or emotional, like memories for perceived events, than non-PTSD participants. This was actually not supported. And what they found was that people with probable PTSD and non-PTSD actually experienced anywhere from 1 to 3 involuntary cognitions, varying degrees and with varying frequency in time experienced. And finally, for the third hypothesis, the non-memories would be phenomenologically comparable to memories. This was supported. And what that means is that the non-memories were hard to differentiate from actual memories experienced. So there was a difficulty in being able to tell whether or not the memory was real or a false memory. In this graph, you can see the differences between probable PTSD participants and non-PTSD participants in their personal memories, which are memories that are unique to the person. And then in generic memories, which can be things like, oh, I saw a man walking a dog, but not being able to put a date and time to it. Elaborative cognitions, which are being able to state date and time references, such as I saw a man walking a dog by my house on 4th Street on Tuesday at 2 p.m. And then there's evaluative cognitions, which are often felt more strongly in those who have lost family members, been involved in car accidents, or other traumas that there was a loss. Often these are viewed in hindsight as, oh, I could have done this and they'd still be here. If only I'd have been there, maybe they'd still be alive. A lot of guilt and remorse surrounding the evaluative cognitions. The second study that I found for PTSD looks at learning and memory deficits. The theory was that there's a deficit in learning and memory exhibited by combat veterans suffering from PTSD more vividly than non-combat veterans or combat veterans without PTSD. The hypothesis was to determine if PTSD contributes to the learning and memory deficits exhibited in combat veterans, as opposed to non-combat veterans or veterans without PTSD. Methods of this study were participants were randomly selected using a convenience sample at the Dorn VA Medical Center in Columbia, South Carolina. There were 148 participants recruited, and they were compensated $25 for their time. Participants self-reported and assessed using Mississippi PTSD scale, the CAPS, Wechsler's memory scale, number 3, logical memory and verbal paired association questionnaire, among others. The results of the study showed a marked deficit in learning and memory in combat veterans who did suffer from PTSD. They scored lower in vocabulary and declarative memory tasks compared to non-combat veterans and combat veterans without PTSD. The hypothesis to determine if PTSD contributes to the learning and memory deficits exhibited in combat veterans as opposed to non-combat veterans or veterans without PTSD was supported with this finding. In these charts, you can see that there is marked differences in the combat PTSD participants. They scored lower in the WMS vocabulary subtest, in the verbal paired associated scales, and the memory index scale. These tests were given in addition to the previous mentioned surveys and questionnaires to assess if there was a noticeable difference in those that were considered to be combat veterans with PTSD, and that these are the findings. In the following slides, Cynthia will discuss PTSD and attention, more specifically focusing on eye contact and facial expressions.
For my topic, I did it on post-traumatic stress disorder and attention. In my first study, I did it on the effect of direct eye contact and PTSD related to interpersonal trauma, an fMRI study of activation of an innate alarm system. The theory is that eye-to-eye contact is being able to distinguish other people's mental state, such as desires, opinions, perceptions, or attitudes. Those are also known as mentalizing, theory of mind, or mind of theory. And it was hypothesized that the control healthy individuals will respond to direct gaze and activate brain regions that have to do with mentalizing. As for those with PTSD, direct gaze will activate the brain areas that have to do with the subcortical root of direct gaze processing, which is the innate alarm system. For the methods, there were 32 female participants, 16 which were healthy individuals and 16 that were diagnosed with PTSD due to childhood trauma. What was used to test the eye contact was using a virtual reality functional magnetic resonance imaging paradigm involving direct versus avert gaze, and the emotions that were used in the experiment were happy, sad, and neutral. Results from the study showed that the healthy control group has shown a significant response in their dorsal medial prefrontal cortex, their left temporal parietal junction, and right temporal pole. In comparison, the group with PTSD showed more activation in their superior colloculus / paraaqueductal gray and their locus coeruleus. The interpretation I got from this study, so the results from the control group had longer direct eye gaze, which has to do with their top-down processing. In this case was the social cognition, and that affects the social interactions between others. Top-down processing also has to do with high-level social cognition. So top-down processing is when higher cognitive processing is used, such as thinking, sensation, and perception. And it was hypothesized that those with PTSD had higher activation in the SC/PAG and LC when responding to eye contact, and results showed that to be true because in the experiment those parts were activated, and those were the innate alarm system. Those with PTSD had higher activation in their SC/PAG, and LC because past trauma has their body unconsciously see that as a potential threat. The reason why those with PTSD see eye contact as a threat because they associate eye contact with getting abused, and then that stimulates their dorsal PAG/SC, which is what causes anxiety-related responses, which is like the fight or flight, or automatic responses of panic behavior. Those with PTSD did not have high activation in the same brain areas compared to the healthy individuals, so that means their reaction to the characters in the experiment were not as fast as the healthy individuals. Because their reactions were not as fast, it shows they have a lower state of consciousness and are not able to quickly perceive other people's intentions or emotions. So the ones with PTSD were not able to use top-down processing the way the healthy individuals were. In my the next study I wrote about, it was the association between facial expression and PTSD symptoms among young children exposed to the Great East Japan earthquake. It was hypothesized that facial emotional expression can be a good marker of emotional numbing among young children who have been exposed to severe trauma. For the methods, there were 23 children between the ages of 6 and 8, and in the methods, the children were shown a 2-minute long video that had scenes of nature in order to get their emotional reactivity baseline. They made sure that the scenes were carefully picked out not to show anything that could have reminded the children about the earthquake. Once the baseline emotional reactivity baseline was recorded, the children were shown 2-minute video clips from a TV comedy show, Mr. Bean. Their facial expressions were then recorded using a face reader software. The results showed neutral facial expression was associated with PTSD in the young children, and that is due to traumatic events. It could have impacted their brain development on emotional processing. Interpretation. Emotional processing may affect one's cognition ability to recognize certain things. Emotional processing also helps with cognitive speed and ability. So if trauma has happened and emotional expression is limited, then the cognitive speed and accuracy will be affected as well. And also the experiment, from the results, it support the hypothesis that those with PTSD did not show any emotional expression to an emotional stimuli. And to conclude our presentation, for some of these cognitive functions either suffered merely a deficit or complete failure, causing those diagnosed to be unable to recognize social cues and causing social interactions to suffer, whereas in other cases it produced a deliberating effect, making daily function difficult. Whatever the case, we are able to recognize that in clinical disorders have significant impact on the lives of those living with the disorders.